Good evening, everyone. Welcome to my series of talk on Alzheimer's disease. We have a program and talk organized for the next 6 months, and we are kind of a third of the way through. If you are interested, you can search up my name and a series of dementia talk on YouTube. And if you are interested, you can go to our website at www.primehk.com.au or send us an email on info@primehk.com.au, and we'll certainly send you the link to my previous 4 or 5 talks. Now tonight, it's very difficult not to talk about clinical evidence and a bit more science behind the current treatment options available for Alzheimer's disease. For the past 3 or 4 talks, I've been trying to simplify Alzheimer's disease, but this talk is invariably, we have to talk about clinical evidence, and there will be some complex graphs that I have to show you, but I'll try to simplify as much as possible to make it relevant to you. We start off with this slide, which shows a functioning neurons. What's a neuron? It's the fundamental unit of nervous system specialized to transmit information to different parts of the body. The neurons are found throughout the body, but in particular the central nervous system and the peripheral nervous system and the spinal cord. So on the left of your screen, you will see a normal neuron. And on the top right corner of the left graph side of that graph there, it's like a spider leg connecting one neuron to the other. And a synapse, it practically means a connection between one neuron and the other, where the legs met each other. Among the first few talks, this is one of my favorite slides because it really summarizes the essential function of our central nervous system. We have different parts of the brain, and I'll go through that in detail next slide. But the most important part I want to highlight here is this part deep inside the brain called hippocampus. It is what I call a manufacturing center. It's mainly responsible for organizing all the incoming new information from various parts of the brain into new memories, into emotions, and into behavior. So it's a remarkable organs in the brain that it is the first organ to be affected in people suffering from classic Alzheimer's disease. Very briefly, let me go through the function of each lobe. The frontal part of the brain control mainly movement, decision making, social behavior, problem solving, planning, and emotional regulation. The parietal, which is on the side of the brain behind the frontal lobe, is processing sensory information such as touch, temperature, pressure. The temporal, which is right behind our ears, it processes auditory information, what we hear from the environment, and able to transmit the information back towards the hippocampus, and the hippocampus will then process whether this voice we have heard before or whether this voice or noise is something that we have to commit to our memory. Occipital, which is the back part of our brain, it processes visual information, what we see. So it's a very, very simplistic description of the function of each lobe. Now, this slide shows normal neurons, a cartoon, and also the neurons in Alzheimer's disease. In normal neurons, each neuron connect with one another. In Alzheimer's neuron, for example, that what is thought to be causing Alzheimer's disease is these abnormal plaques, which is persistent and unable to be eliminated from the central nervous system. And also, it has something called neurofibrillary tangles within the cell. So there's some insoluble protein outside the cell and some insoluble protein inside the cell. And on the bottom of the slide there, it is what we call electron microscopy. And that is a detailed definition of each of the functioning neurons. And the dark part, if you like, look like a bruise, that is the abnormal protein that we are referring to. Causes of Alzheimer's, really in summary, is unknown. It is thought to be due to the amyloid entangles causing a cascade of chemical imbalance, and also that has led to a conduction deficit, meaning conduction between the two neurons are affected because of this insoluble protein. So this is the understanding over the past 124 years, because the first described in early 1900. And so treatment, logically, the scientists are looking for the reason of the cause of the protein, so-called amyloid. And we're looking for solution to break up this insoluble protein, the amyloid. Then we also look for a solution or medication to remove the abnormal protein, the amyloid, and also to replace the chemicals that has been affected because of the insoluble protein. So this is logically, this is what we do, and the scientists have been trying very, very hard over the past half a century in trying to develop treatments according to these 4 pillars of belief. Now, what's available so far? After half a century or more of scientific research, at best we can come up with 2 classes of medication. Now, before we move on from this slide, there is another class of medication which I deliberately left out because it hasn't been universally accepted as a treatment modality, and I'll mention that towards the end of my presentation. Coming back to this slide, the 2 classes of medications are cholinesterase inhibitors. Broadly speaking, there are 3 in this family, and NMDA receptor antagonist, which is 1 medication in this category. Now, I know there's a lot of mumbo jumbo here, so I just want to quickly summarize. The cholinesterase inhibitor A is designed to stop an enzyme inside the cell that destroy a chemical that are essential for the functioning and the survival of each individual neuron. So if we stop that enzyme from destroying that particular hormone, that means it gives more chance for the hormone to work, so therefore the cells survive better. That's really very simplistic. The second class of medication is called NMDA receptor antagonist. What it is that this medication is designed to increase the activity of an enzyme that breaks down a hormone by the name of glutamine, which are thought to be too active in Alzheimer's disease. So it's almost the opposite. One is to make sure the hormone that's essential or the chemical to for survival, and then the other class is to destroy the hormone or chemical they are thought to be overactive. So 2 different class of medication. And so in summary, really these 2 classes, we know that evidence from the laboratory studies indicates that these agents could potentially attenuate neuronal damage and death from cytotoxic insult, and therefore might affect Alzheimer's disease pathogenesis. In other words, from the laboratory studies, we know that this agent potentially could increase the connection between the 2 neurons. But who knows that what happened in the lab could be very different what happened inside human body, in particular the brain in this condition. This is exactly what the scientists have discovered. Let's talk about the stages of cognitive impairment. We, broadly speaking, have 2 broad stages of cognitive impairment. The first one is pre-Alzheimer's disease. Under pre-Alzheimer's disease, again subdivided into two sub-stages. The first one is called preclinical, and the second one is called prodromal. The preclinical stage is before a clinical diagnosis of a cognitive disorder is considered, meaning this person is completely asymptomatic, means no symptoms. If it wasn't because of the advanced medical technology detecting the changes in the brain, you would have never known this person have the changes which may lead to Alzheimer's disease in 10 years' time. Second sub-stage is called prodromal. Now at this stage, there are clear cognitive impairment, called mild cognitive impairment due to Alzheimer's. And there are obvious symptoms of brain dysfunction, but by and large, the person is still 100% independent in all his daily function. So apart from then we come to Alzheimer's disease, which is a cognitive impairment led to the loss of independence, and it requires supervision and assistance. Preclinical Alzheimer's disease at the moment, what are the clinical evidence? Currently, there are no approved drug for this stage. Preclinical means completely asymptomatic. If you see that person on the street, he would be just like you and me. But there are active trials are going at the moment, and also other non-drug therapies. At this stage, at this point in time, our recommendations are generally as follows. We believe that controlling the blood pressure, controlling the blood cholesterol, increasing in social activities, involve yourself in new activities, such as going to a day activity center organized by the council locally, and also our prime garden, Mount Albert North, which we have started and led by a professional diversional therapist. We welcome further inquiry about that. And also Mediterranean diet, which is olive oil-based diet, and of course the exercise. You probably noticed that this recommendation have been given to people with heart disease or with stroke. So it's not much different from people who has the potential to develop Alzheimer's disease. Now, with the prodromal or mild cognitive impairment aid Alzheimer's disease, currently the Federal Drug FDA of USA approved a treatment called cholinesterase for mild cognitive impairment, because but the evidence was not as strong as we would like, but it has been approved, but hasn't been universally adopted yet. And in Australia, I do sometime in clinical practice consider using cholinesterase inhibitor. What about the Alzheimer's disease itself? Currently, the monotherapy or single treatment with one of the three cholinesterase inhibitors, or combination of one of the three inhibitors plus NMDA antagonist, which is memantine, has been shown to have some benefit in improving the cognition or the cognitive function, but doesn't really quite translate into a full clinical benefit. So that's where we are at in terms of the evidence. So all of the cholinesterase inhibitor, it acts by inhibiting the enzymes called acetylcholinesterase, and therefore increasing the concentration of acetylcholine, which I mentioned before in the previous slide, that is an essential chemical that maintains the integrity between the connection of two neurons. And the connection of two neurons are essential to form new memory. So this is how it works. So far, all these medication that's on the left of the screen, the donepezil, the rivastatin, and the galantamine are available in Australia. We only have a patch of rivastatin, we don't have an oral formulation. But by and large, all the rest is available here. And all of them, although they are from the same family, they have slightly different characteristics. So, what are the current evidence for Alzheimer's disease? Let me take you through the clinical evidence now. That's where I'm going to show you a series of graphs, but stay with me and I'll try to simplify that as much as possible. The donepezil and rivastigmine are for mild, moderate, and severe, meaning the whole spectrum of Alzheimer's disease. Galantamine is approved for mild to moderate dementia, while memantine is approved for moderate to severe dementia. In other words, these two classes of medication, the 3 in class A and 1 in class B, in combination or alone, has been shown to be effective in the whole spectrum of Alzheimer's disease. But none of these drugs slow the progression. It does some improvement, it has some improvement, but it does not slow the progression of the disease, which in other words, the disease is irreversible. This graph basically shows on the top is a combination therapy of the memantine plus one of the 3 medication of cholinesterase inhibitor. The middle of the graphs is a monotherapy, meaning that either one of the 3 that I have mentioned, and the lower end, the lowest graph there, it shows no medication. So obviously from the graph perspective, you can see the combination therapy does have some benefit over single therapy and over no therapy. So no doubt it actually worked, but whether this working in the laboratory and testing, doing a paper test, translate actually to day-to-day physical and functional benefit, it is very difficult to tell. And in my clinical experience, only a third of my patients respond to this medication at the best scenario, in the expense of unacceptable risk for side effects of this medication. So, the NMDA receptor antagonist, this is a cartoon depicting what it meant, is that this medication is stopping or is enhancing an enzyme that breaks down the glycine and break down the glutamine, which is thought to be harmful to the brain if it becomes too active or too concentrated in the body. And I'm going to show you this graph. It shows that definitely all the medication that put together, this is a monotherapy compared. And obviously the bottom half of the graph, no medication. The top half, the 3 lines shows them on medication, and it's definitely beneficial. On the left, it shows this called ADAS. ADAS is a name which is a type of a test that the doctors do. It definitely shows clinical improvement and compared to no therapy, for sure. It's an article which formed the very important, give us very important information about the combination therapy, how it works in human being, and it certainly shows a definite benefit in a treatment of moderate to severe Alzheimer's disease in terms of cognition, behavioral disturbance, activities of daily living, and a global assessment, and was quite well tolerated. But bear in mind that this sort of patients who are involved in clinical trials, they are usually very, very healthy otherwise. In a clinical scenario, the patient I saw in my clinic, most of them, 90% of them, are very elderly, and they have a lot of other medical conditions and medications, so making the side effect a bit more prominent and important to talk about. So, this is the slide that I have shown you before. This is the published the researcher by the name of Schneider. Now, I mean, is this the beginning of the end? We have tried so many decades now, over a century, trying to find out, trying to do research and spend trillions of dollars of US dollars, but then we are unable to find a treatment that is able to reverse Alzheimer's disease. I promise you, I will give you, this is one of my last slide. Nowadays, you probably hear from the media that there's something called immunotherapy for different stages of Alzheimer's disease progression. Immunotherapy is completely different from the classes of medication which I have spoken to you about. Immunotherapy are targeting using our own body immune system to either stimulate it, and so therefore the own body immune system go and remove the abnormal protein, the amyloid, or we can actually give vaccination to stimulate our immune system so that it will produce the antibody to remove the insoluble protein. So basically what it means is one is active, one is passive immunization. I won't bore you with all this, but as you can see from this graph, that from all the way from the left of the slide, the preclinical, which again, let me remind you, is someone that's on the street that you see, you would not ever think that he might have Alzheimer's disease unless you do a special test on his brain. To the right of this slide, which is severe Alzheimer's disease, and you can see the scientist has been trying very, very hard in different types of immunotherapy in different stages, and so far it's only one medication has gained approval in the United States. So we know there are emerging evidence to suggest Alzheimer's disease is not an irreversible condition, by the way, because we know that Alzheimer's disease is caused by multiple factors, and we know at least there's a group of scientists from America is advocating at least 36 factors are found to be contribute. And what they are proposing is that it's quite unorthodox according to the mainstream doctors, the neurologists, and the scientists. What they're proposing is that the abnormal protein, which is amyloid, is there for a reason. It is there to counteract some kind of infection, some kind of hormonal deficit, some kind of minerals deficiency, for example. So therefore, it is not at the end of the road yet. I think this is gaining momentum, and I'm interested personally in knowing a little bit more about this, and will certainly keep you up to date. Again, as I say, that if you're interested in knowing a bit more, listening to my to the previous talk, and please feel free to go to YouTube, and you can search under this topic, Understanding Dementia Part 1, Part 2, and also the link at the bottom. But if you can't see it on the slide, I apologize, but please do give us an email at info@primehcare.com.au, or check our website regularly, www.primehcare.com.au. Until then, have a good night and see you next time.